So it's Friday, so it's time for Poets. Some of us know that as Push Off Early, tomorrow's Saturday. But in this context, it's the Perioperative Enhancement team. Inspired by Dr. Sol Aronson and the team at Duke, a selection of clips to get us thinking about the next steps in providing world-class perioperative care. You'll find the full lectures in our back catalogue, or join us at the upcoming Perioperative Practicum for expert discussions, business case tips, and hands-on workshops. Go to www.ebpom.org and look for our international programme of perioperative practicums. Top Bed Talk. I'm joined by my co-hosts Desiree, Chappell and Joff, Lacey, with special guest Dr. Mike Swart. Mike, tell us a little bit about yourself.
Well, I'm a consultant in anaesthesia, perioperative medicine and intensive care in Torbay Hospital down in Devon.
Now, maybe in part it relates to the geography, but your hospital and your area has been well known in our healthcare system in the National Health Service for being very innovative, particularly in the perioperative area. I mean, don't have time to go through the whole list, and we'll come to one of your national roles in a second, but in particular, evaluation of risk and communication of risk and shared decision making.
Well, going back about 20 years ago, my colleague John Carlisle, who is a consultant colleague at the moment but was originally a trainee with us, we got into cardiopulmonary exercise testing. And we got into that through seeing the work of Paul Holder from Melbourne. And what we thought was going to be a very sort of simple, you do a test, you get a measurement, and the man from Monty says yes or no to having an operation. We quickly moved to realise that it wasn't about a number, it wasn't actually just about a risk prediction, it was about consultations to find out what patients wanted.
And has it helped? I can understand, I mean, I know quite a lot about cardiopulmonary exercise testing, seen quite a lot of it. I think the patients find it very tangible, because you get on a bike and you're fitter than you expected, or you're as unfit as you thought you were. But let's imagine the patient's very, very unfit now. How do you allow enough time to counsel a patient to allow them to possibly reach a decision that the surgery that they thought they were going to get is now not in their best interest? Sounds very time-consuming.
Well, first of all, you don't have to end the first consultation with a decision.
Right.
Also, patients are not just seeing us, they're seeing surgeons, they're being discussed at MDTs, and actually the most important thing you learn is where decision making is difficult, don't do it quickly.
Okay, so give it
time, bring people back.
So I'll hand over to my colleagues with some questions in a second, but I remember one series, I don't know if I'm quoting it correctly, early on in the days of hearing you talk about it, of aortic aneurysm patients who eventually decided not to have their aortic aneurysm repair, and the vast majority died with their aneurysm intact. Is that right? Or is that a bit simplistic?
It's probably right.
Right.
But I'm choosing my words carefully because we don't have thorough follow-up.
Okay. But many of them decided... What sort of percentage... Some people are now throwing around numbers like over 65 given the opportunity. Is it maybe as much as 15 to 20% of patients given the opportunity not for surgeries?
I think aneurysms is a dynamic process because the aneurysms change in size. The patients change in age. So patients in the UK with abdominal aortic aneurysms are predominantly male, and they're picked up through two processes. One is the UK national screening programme that offers ultrasound screening to all males aged 65. Or they present as victims of medical imaging technology, otherwise known as vomits.
Right.
Now, a vomit is where you have some other symptoms, say abdominal pain, and you end up with a CT scan that then finds your aneurysm. Those patients then are seen by vascular surgeons when the aneurysm reaches 5.5 centimetres, but actually we see them earlier. We see them before the vascular surgeons as part of preparation for possible future surgery. So there isn't you see somebody and it's yes, no. There's an evolving process, and we may see people over a 10-year period as their aneurysm changes in size and decision-making changes.
And in the MOOC, the Perioperative Medicine Royal College of Anaesthesiology UCL MOOC, I've watched a video of you demonstrating a protracted discussion process, which I found very, very educating. It was you didn't get off the fence. You gave them options to go away and think about.
Well, I think that's a very key bit. Is our job is not to give our own personal opinions. Our job is to give people information to help them make decisions.
Mike, your description of how you approach the shared decision-making process, particularly with patients in which having an operation might not be in their best interest, is one that sounds like involves a lot of time. And I think there'll be a lot of people listening saying, well, I would like to do that, but I'm not given the opportunity or the facilities to do so. So what is the setup for you? And if it's different from most people, which I imagine it is, how do you go about getting a similar kind of enterprise?
I think that's a good question. We do not reflect standard outpatient appointments in the UK. We've developed a clinic where we have 1 hour for both a consultation and, if appropriate, a cardiopulmonary exercise test. What I would say, though, is we're doing things different to other outpatients. We screen who we need to see. Right. So in Torbay Hospital, we do about 10,000 operations a year. Now, we see about 850, 900 patients in that clinic. So we're selecting out the either high-risk patients based on age and comorbidities or the surgery. So if you design your outpatient service to what you need, you can allocate an hour.
And who's filtering that out? Is that the pre-assessment nurses, or...?
It's a combination of... we do have some standards for who we should see.
Yeah.
That we can get referrals from the pre-assessment nurses. We do get referrals from individual consultant surgeons, and we get referrals from general practitioners.
And then you also have the opportunity for repeated clinics with patients to see them time and time again as long as needed, or what's...
I wouldn't say we don't set a repeat clinic.
Right.
They may come back in the guy in the MOOC, he came back 8 years or 8 years after his original EVAR because there was a complication.
And in setting up the setup you have at the moment, did you have was there difficulty in that? Did you have barriers that challenge your ability to get that up and running?
I think we've got the advantage that we've been doing it 20 years. So when we started, we actually started with seeing elective aortic aneurysm patients in our own time, and actually we borrowed the respiratory physician's CPET equipment. So we would be seeing people either before their clinic started in the morning or at the end of the day. We then developed with our vascular surgeons a demand, and the vascular surgeons valued what we were doing. And then we moved into colorectal, then we moved into orthopedics. So we've gradually built in a sort of stealth-like way. Where I would say we can justify ourselves is we have outcome data in a publication that says if you went to our clinic, you lived longer. And when we were challenged by the medical director, who's a gastroenterologist, we were able to say, can you demonstrate the benefit of your clinic?
Wow, that's an amazing way. The only way to get buy-in there. That's great. It sounds like it's been a real collaborative approach over the years in bringing in the different team members. Can you speak to that a little bit about who that really involves?
I think you need to provide a service to the surgeons that they want, and then you need to develop and learn a way of working together. So, for example, we don't actually attend all the multidisciplinary team meetings that are around surgical decision-making, but we do have good communication through direct face-to-face contact, phone calls or letter writing to communicate what the outputs from our clinic. You also need to actually develop what I would say is a very broad but superficial knowledge of all surgery and all medicine, so that you understand what is in there, what the processes or thoughts that are going on within the different surgical specialties.
Yeah, it sounds like there could be a pretty labor-intensive training for that group too.
I think it's something you learn with time.
Yeah.
And while some of it could be taught, it's actually about building up relationships with your other colleagues.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising it at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look.